Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features educational content from our conference coverage program titled CROI 2022, Clinical Impact of New HIV Data. In addition to this podcast, we encourage you to check out the full program on our website, where you can watch on-demand webcasts of our rapid post-conference webinars, read clinical thought commentaries from physicians around the globe, and download curated slide sets showcasing key studies from the conference. Remember, you can find that link to the full program in the show notes for this episode. The podcast you're about to hear features two HIV pharmacists discussing key studies presented at CROI 2022. I'm delighted to introduce them both, starting with Fidelia Bernice. She's a clinical pharmacy specialist in infectious diseases at the University of Maryland Medical Center in Baltimore, Maryland. Joining her in conversation is Jennifer Cocohoba, who is professor in the Department of Clinical Pharmacy at the University of California, San Francisco. So let's get started and hear what Drs. Bernice and Cocohoba have to say about exciting new HIV data presented at CROI 2022.
Hello, I'm Jennifer Cocohoba, and I'm a pharmacist at the University of California, San Francisco Medical Center Women's HIV Program, as well as a professor at the University of California, San Francisco School of Pharmacy. I'm excited to be here today to be with my colleague, Dr. Fidelia Bernice, and we're here today to talk with you about some exciting studies that were presented at CROI.
Very happy to be here with you, Jen. And I'm Fidelia Bernice. I'm an infectious diseases pharmacist at the University of Maryland Medical Center. So the first study we're going to discuss today was a pharmacokinetic study of an investigational drug, Islatravir. So this is a very interesting study assessing the use of this investigational oral Islatravir for PrEP. Islatravir is a really ideal option for PrEP given its oral availability and long half-life. There are actually multiple formulations of Islatravir that are currently being investigated, including a once-monthly oral tablet and a once-yearly subdermal implant. The study that was presented at CROI focused on the once-monthly oral tablet, assessing its pharmacokinetics and looking at concentrations of the parent drug Islatravir and its active component, Islatravir triphosphate, in blood, rectal, vaginal, and cervical tissues. The study included 54 adults at low risk for HIV acquisition and found that 95% of samples had quantifiable amounts of the parent drug, and over 88% of the samples had quantifiable amounts of the active component, Islatravir triphosphate, across all tissues and time points. When they looked at trough concentrations, they found that they were similar between mucosal tissues, and also saw that at week 4, Islatravir triphosphate concentrations in blood and rectal cells exceeded the PK threshold for prophylaxis by 20-fold and 4-fold respectively, and very promising. These results are very promising in that we saw good amounts of both the parent and active component of Islatravir across different mucosal tissues, making it a very attractive drug and formulation for PrEP. We know that currently we only have 2 options for PrEP, a daily oral pill, as well as a monthly intramuscular injection. So these results are very promising for potential additional formulations coming to the market. Jen, what are your thoughts on this study that was presented?
I think it's also exciting to have all these options for PrEP coming down the pipeline because we are 10 years out from the approval of the first PrEP therapy back in 2012. So it's about time that we've gone beyond the once daily take a pill prevention method. I think we need to come to modern therapy. And this is an example of one of them. It's still oral, but at least it's once a month, so you don't have to worry so much about remembering to take your dose or complicated dosing strategies. I think this will be an exciting tool to have in our toolbox. I think we'll have to wait to see. I know that some of the studies were being halted to explore some impact of Islatravir on CD4 lymphocytes, the total and the T cell counts, and hopefully we'll have more information about that coming in the future. In addition to the Islatravir studies that were presented at CROI, they did also present information about another modality, which is the tenofovir vaginal ring. And I think most people are probably familiar with some of the older tenofovir gel studies, the vaginal gel studies. They didn't perform so well mostly because of adherence. Participants had difficulty using the medication every day. There may have been issues around privacy and access to actually inserting the vaginal gel. So I think the idea of delivering tenofovir vaginally has now been push towards putting it inside of a ring. And this was the MTN 038 study. And notably, it's a phase 1 study. So this is early in the tenofovir vaginal ring development, and this is done in healthy volunteers. And the idea of these phase 1 studies is really just to focus on safety, pharmacokinetics, the adherence, and the acceptability. So there were 49 persons in this study who wore or inserted the tenofovir vaginal ring for 91 days, a 3-month period. And they underwent cervical tissue biopsies to get concentrations of the drug. They also measured residual drug left over in the ring. And what this study found was that there really, from a safety perspective, there weren't differences in genitourinary adverse events. And the adverse events they did record seemed to be unrelated to the ring. They were vaginal discharge, things like uterine spasms, or dysmenorrheas. In the pharmacokinetic portions of the study, they found the maximum concentrations happened at about a month, was 34 days. And the concentrations remained pretty high at some of the scheduled time points. So at 2 weeks, even all the way out to 56 days, concentrations were high, especially in cervical vaginal fluids. But the concentrations did decline pretty dramatically at day 91 across all compartments, plasma, cervical vaginal fluid, and rectal. And especially when you removed the ring 4 hours later, the concentrations dropped even more. It was interesting for the rings when they studied how much drug was left over. It was almost all the drug was eluted from the rings in most participants. And for those participants who had sort of high release of drug from the ring as compared to other persons, there wasn't any strong markers of sociodemographics or sexual activity or other vaginal flora scores to explain why some people, absorbed drug from the vaginal ring more completely than other persons. And I guess in short, the tenofovir vaginal ring was very acceptable. People liked it. They rated it a score of 8 on a scale of 1 to 10, and also said 9 out of 10, they were really likely to use this potential PrEP option. So Fidelia, what do you think? Where are we with the development of rings for PrEP? And do you think this is going to be an important option to add to our armamentarium?
Yeah, but I think the thing that's most exciting to me is how much the individuals liked and accepted the formulation, right? I think a lot of times that's half the battle, is getting formulations to people that they can actually use and that work for them. So the fact that, people didn't find this a hindrance or a barrier or anything like that is very promising for future formulations for PrEP.
Absolutely. And I think it's so important to really have female-controlled options for PrEP, and the promise of being able to combine these potentially with birth control. I think it's really exciting.
Absolutely.
Yeah, speaking of hormones, I think there was an important study on hormones and PrEP also presented at CROI.
Yes, there was. So there was this study that was looking at the bidirectional effects of hormone therapy and PrEP in transgender individuals. I think this is a really interesting study and really important for targeting different individuals that we know are affected across the HIV continuum, right? So this was a hormone sub-study of transgender individuals who were on PrEP. It was a pharmacokinetic analysis, and individuals had their tenofovir diphosphate concentrations evaluated in blood, and as well as their serum hormone concentrations evaluated at weeks 0 and 12. They included over 150 individuals in this study. There were 91 transgender women who were on stable estrogen. And when they looked, estrogen concentrations didn't actually change significantly between week 0 and weeks 12 in those taking and starting PrEP therapy. They looked at 60 transgender men on stable testosterone therapy and also found the same, that their testosterone concentrations didn't significantly change when taking PrEP between weeks 0 and 12. Like I said, they also reviewed tenofovir diphosphate concentrations, and these were not significantly different in transgender individuals when they compared those who were on hormone therapy and those who were not. I think this study is really important because one of the big things, especially as pharmacists, that we're constantly concerned with in our patients are drug-drug interactions. So this study gives us some information about neither one of these very important classes of drugs interacting or causing problems with one another. What are your thoughts, Jen?
Yeah, absolutely. I think some of our persons of trans experience worry that PrEP might interfere with their hormone therapy. And we recognize that that's such an important part of their day-to-day experience and their day-to-day care. So I think this study provides some reassuring data that we can share with our patients that really, you can do both. You can protect yourself and sort of achieve your transition goals with your medicines without them interfering with each other. And again, that's happy news for our communities.
Absolutely.
Yeah, and I think as pharmacists, we do worry a lot about drug-drug interactions, and not only pharmacokinetic drug interactions, but pharmacodynamic interactions. And there was a study presented at CROI looking at anticholinergic medicines and their impact on persons aging with HIV. And anticholinergics, they're always a concerning class, right? As they're on the VIRS list, we have lots of concerns for the adverse effects like dry mouth, urinary retention, constipation, and then maybe more seriously, things like falls, frailty, and cognitive impairment. So this study was actually based out of the POPPY cohort, and the POPPY cohort's out of the UK. It is specifically a cohort that studies persons aging with HIV, and they've got a subsection of their participants who are over 50 living with HIV. They've got persons who are under 50 living with HIV, and they also have a cohort of persons older than 50 who do not have HIV. So different comparison groups. But this particular study looking at anticholinergic medications only included persons living with HIV who were over the age of 50. And what this study did was it took the baseline data for this subsection of the cohort and looked to try to assign an anticholinergic medication risk score to each of their baseline medications. And they used 3 different scales to do so. There were a couple of American anticholinergic risk and burden scores, as well as a Scottish guidelines network scoring system that they used. And basically, if the medication scored higher than 1 on any of these scales, it was counted as an anticholinergic medication. They looked at these medications in relations to 2 specific outcomes. They looked at recurrent falls, which they defined as having 2 or more falls in the previous 28 days, as well as frailty, which they used Fried's criteria to measure frailty in these patients. Overall, in this study, they found that there were 9% of persons who met that outcome of recurrent falls, and 32% met the frailty criteria. About a third, or 27% of the cohort, had any anticholinergic medication on board. 9% of persons had 2 or more anticholinergic medications. And the most common ones that appeared were things like codeine, citalopram, loperamide, amitriptyline, diazepam, and cetirizine, and all really commonly prescribed medications. What was found in the study basically was that anticholinergic medications seem to be associated with both outcomes, both falls as well as frailty. Although after adjustment for demographic and lifestyle factors, the odds ratios, as high as they are, were not necessarily statistically significant because their confidence intervals crossed 0. The one statistic that looked kind of interesting and actually makes a lot of sense is that if you had 2 or more anticholinergic medications, you definitely had a higher odds of recurrent falls. And even after adjustment for sociodemographic factors, that statistic remained statistically significant as well. So I think this study for me just reminds me and highlights how important it is for pharmacists to review medications, for drug-drug interactions as our patients request them, or just really to take those opportunities we have to optimize patients' therapy for safety. And I don't know, Fidelia, do you see a lot of anticholinergic medications in your practice as well?
Yes, unfortunately. And we know that we have an aging HIV patient population. And I agree with you, highlighting the importance of a pharmacist review and assessing, is each medication actually warranted? Does each medication still have an indication? And is this patient required to be on that? Because we see that there can be actual real life consequences and harms that come to our patients if they're on these medications inappropriately.
Absolutely. We've got our work still cut out for us.
So I know that we're both passionate about caring for people who are living with HIV, and we know that ultimately adherence is an extremely important part of their care. This was a retrospective analysis that assessed factors associated with poor adherence to antiretroviral therapy among Medicare beneficiaries living with HIV. When they looked at factors that were associated with lower adherence, they found younger age, female sex, Black race, Hispanic identity, lower income, having a higher comorbidity score, or being on a protease inhibitor as your base therapy, as well as mental illness or substance abuse being factors that were significantly associated with having lower adherence. It was also determined that all-cause HIV-related hospitalizations as well as emergency visits were higher in those who had lower adherence, and therefore they had higher medical costs. But seeing that we had our HIV-positive patients with lower adherence had higher rates of hospitalization and emergency visits and had higher cost of care, it demonstrates the significance of having to promote and improve adherence in our patients as much as possible, because there are real life consequences that they could face because of this. Especially, we notice that the risk factors that were highlighted are a lot of vulnerable populations, right? Especially our patients who deal with mental health issues and substance abuse issues. So we know that there are new antiretrovirals that are coming to market, both for treatment and prevention of HIV, but we have to continue to underscore the importance of supporting adherence in our patients. So I talked a lot about the different formulations. We can have the best drugs, but if our patients can't get them or they can't take them, then they're not going to help them. This was a nice modern study that showed that adherence is still an issue and it's still something that we need to be cognizant and aware of. What do you think about this study, Jen?
Absolutely. I think it only underscores how important adherence as an issue remains in our patient populations. I looked at this study, and although the 53% with the near perfect 95% adherence looked okay, I saw it as the flip side. I'm like, gosh, 47% of persons had less than 95% adherence, and that's almost half. We need to do better by our vulnerable populations. We need to find ways to support people in culturally humble manners. We need to link people to care for mental health and substance use to facilitate success to antiretrovirals. And I think people sometimes forget that the pharmacist is such an important part of that continuum, but we can offer so much, not just access to the medicines, but really, being part of the team that helps recognize and identify adherence issues and also proactively takes parts in the solutions.
Jen, given the importance of adherence to our patient population, what would you say is one of your main tools for assessing adherence?
There's a lot of potential strategies for assessing adherence, but honestly, I just ask. And I think I'm often surprised at how much our patients will tell you. And I don't know if it's because they think we have secret refill information on them, sometimes, which we do as pharmacists have information about their pickups and the dates they've picked up. But I think, if you approach the patient with honest curiosity and that desire to really help support them and let them know you want to support them, people trust our pharmacists, right? They'll often tell you things that can be really helpful in their adherence.
Yes, I 100% agree. It's amazing how that simple question can lead to a depth of information that other providers don't always have or aren't able to elicit. So I definitely agree with you. So Jen, I really want to thank you for discussing this data from CROI with me. I know our listeners greatly appreciate your perspective, and it's been such a pleasure.
Absolutely. It was so much fun to discuss these fun studies, and I hope that the information is useful to our audience.
Thank you so very much to our HIV pharmacists, Drs. Bernice and Cocohoba, for that informative post-conference conversation. And thanks to our listeners for joining in. As a reminder, to view the full program of conference coverage of CROI 2022, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics.